Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Viatris.
This program is presented by Medscape Education Global.
Hello, I'm Vikian Boscurt, Senior Dean of Faculty, Kane Chair, and Professor of Medicine at Baylor College of Medicine in Houston, Texas. Welcome to the discussion titled Beyond SGLT2, the emerging role of dual SGLT1 and 2 inhibition in heart failure. Joining me today is Bassam Attallah, Associate Dean of Clinical Affairs at the Dubai Medical University in the United Arab Emirates. Welcome, Bassam.
Thank you, Dr. Beacom.
Today, we're going to take a deep dive and discuss whether blocking SGLT1 adds to the benefits of SGLT2 inhibition in the prevention and treatment of heart failure, and the emerging role of dual SGLT1 and 2 inhibitors, how to use it, and which patients may benefit from treatment. Let's first start with the established role of SGLT inhibition in heart failure management and address why SGLT inhibitors are now considered foundational therapies in heart failure across the ejection fraction spectrum, and talk about the evidence and guideline indications for use of SGLT inhibitors in heart failure across the spectrum of EF, including heart failure with reduced EF, mildly reduced EF, preserved EF, and also in patients hospitalized with acute decompensated heart failure.
So, Beacom, if we are to begin with HFrEF, what would you say is the contemporary evidence for the selective SGLT inhibition with these agents?
Great question, Bassam. The benefit of SGLT inhibition has been very strongly evidenced across the whole spectrum of heart failure. The first signal for benefit came from the diabetes prevention trials, such as EMPA-REG, CANVAS, DECLARE, TIMI trials, which show that treatment of patients with diabetes and cardiovascular risk or cardiovascular disease resulted in a significant improvement in prevention of heart failure. That was the first signal. Subsequently, large-scale trials were conducted in patients with established heart failure, including heart failure with reduced EF, such as DAPA-HF and EMPEROR-reduced trials, as well as patients with reduced and preserved EF, such as EMPEROR-preserved and DELIVER trials, and also patients with acute decompensated heart failure hospitalized for heart failure, such as SOLOIST and IMPULSE trials that showed SGLT inhibition was very effective and safe, reducing cardiovascular death and heart failure hospitalizations across the whole spectrum of ejection fraction in patients with heart failure. And we also have evidence of safety and efficacy in individuals with chronic kidney disease with trials such as EMPA-KIDNEY and DAPA-CKD trials. To expand on the concept of SGLT inhibitors, I want to first start on talking about the evidence in heart failure with reduced EF. These trials, the two landmark trials, the DAPA-HF with dapagliflozin and EMPA-REDUCE with empagliflozin, was conducted in patients with heart failure with reduced EF, with EF less than 40%, and half of the trial population were with individuals who did not have diabetes. Both studies showed that treatment with SGLT inhibition resulted in significant reduction in cardiovascular death and heart failure hospitalization. This reduction was on top of the background therapy and provided an incremental benefit of 25% risk reduction. And the benefit started very early with separation of the curves as early as within a few weeks, demonstrating that these are disease modifying agents.
So, given this data, Beacom, and you being an expert as well in and being involved in some of these guidelines, how do the guidelines stipulate their role and how should they be used in HFrEF?
In all heart failure guidelines, regardless of which society, such as the US guidelines as well as ESC guidelines, SGLT inhibition is a class 1 recommendation in patients with heart failure with reduced EF. That higher level of evidence, as well as the class of recommendation, is represented as a class 1A recommendation. And the verbiage that is included in the guidelines is SGLT inhibition is recommended to reduce cardiovascular death and heart failure hospitalization in all patients with heart failure with reduced EF, and this is regardless of the diabetes status. And it should be kept in mind in patients with heart failure with reduced EF, we have four classes of medications that are now indicated that are considered the foundational therapies, which include RAS inhibition, either with ARNI or ACE inhibitors or ARBs, beta blockers, SGLT inhibitors, as well as mineralocorticoid receptor antagonists. The order of which does not matter. One could initiate any of the drugs depending on the specifics of the patient, as long as the therapies are optimized within 4 to 6 weeks of the initial diagnosis. The earlier they're initiated, the better it is. And in both the US and the ESC guidelines, SGLT inhibition is given the highest level of recommendation, as I mentioned, and there's definitely concordance of the strength of the recommendation across the guidelines.
If we move next to heart failure with preserved EF or with heart failure with mildly reduced EF per the universal definition of heart failure, what key trials established the role of this therapy in HFpEF and HFmrEF? And I also would like to ask about HF improved EF. Do these patients need to continue to be on such medications?
Great questions. And very similar to the HFrEF populations, we do have very strong, large scale trial evidence for efficacy of these agents in patients with EF over 40%, which straddles the mildly reduced as well as preserved EF populations. Specifically, we have evidence from the large scale Emperor preserved as well as Deliver HF trials, which were very similar, one with empagliflozin, the other one with dapagliflozin, carried out in individuals with symptomatic heart failure with EF over 40%, demonstrating significant reduction in cardiovascular death and heart failure hospitalizations within 2 to 3 weeks of initiation. Back to your question, whether there was any heterogeneity according to EF in these studies by subgroup analyses. There was no heterogeneity, meaning those individuals with mildly reduced EF between 40 and 49% benefited. Individuals with normal EF, with EF 50 to 59, benefited. Individuals even with high supranormal EF greater than 60% benefited. And back to your question of improved EF, there was evidence from the Deliver HF subgroup analyses, which included patients whose EF improved, historically were less than 40%, and subsequent EF calculations being normalized. Even in those individuals, there was evidence of benefits with SGLT inhibition. So in the US guidelines, we state that in individuals, even with evidence of improvement in EF, guideline directed therapies, especially with SGLT inhibition, should be continued.
Thank you. So, having summarized the evidence, what is the current guidance now for their use, and any specific details that we should be aware of, particularly if we think differences between HFpEF and HF mildly reduced EF?
The US guidelines, which were published in 2022, were published immediately after the Emperor Preserved trial. So we had evidence only from one clinical trial. Therefore, when the US guidelines were formulated, SGLT2 inhibitors were given a higher level of recommendation than other agents. But because we only had evidence at that time, with one trial, it was given a class 2A recommendation. The ESC guidelines, which were published in 2023, because they had evidence from two trials, SGLT2 inhibitors were given a class 1 recommendation in individuals with preserved EF. Mildly reduced EF gets the recommendations in terms of the types of agents that are recommended, very similar to heart failure with reduced EF. So in the US guidelines, we do have the recommendations of being able to use ARNI, ARB, MRA, or beta blockers in mildly reduced. In the US guidelines, ARNI, ARB, and MRA are given a class 2B recommendation for heart failure with preserved EF. In the ESC guidelines, mildly reduced EF recommendations are very similar to US guidelines. Specifically, ACE inhibitors, ARNI, ARB, MRA, and beta blockers are given a class 2B recommendation. But for HFpEF, European guidelines did not specify any additional therapies beyond SGLT2 inhibitors and diuretics. So that was a bit of a difference between the two guidelines. But overall, there's concordance for a higher level of recommendation with SGLT inhibition in patients with mildly reduced and preserved EF across all guidelines.
A question that frequently comes up in practice become is their efficacy and safety of starting these medications in hospitalized patients, and when and how should we consider initiating SGLT inhibitors in hospitalized patients who have acute heart failure?
Great question. Simple answer: very effective and safe, even in hospitalized heart failure patients. We have evidence from large scale trials in acute decompensated heart failure patients with SGLT inhibition amongst patients hospitalized for heart failure. In the Impulse trial, which included patients either with a primary diagnosis of de novo heart failure or decompensated chronic heart failure, regardless of EF, when randomized to SGLT2 inhibition with empagliflozin versus placebo, there was evidence of significant improvement in the primary combined endpoint, which included a hierarchical composite of a death from any cause, heart failure events, change in the KCCQ health status at 90 days with a win ratio showing 36% more patients being more likely to be benefiting from the SGLT2 inhibition in hospitalized heart failure patients. In the Soloist trial, which was conducted in patients with diabetes and recent worsening of heart failure, sotagliflozin, which is a combined SGLT1 and 2 inhibitor, when initiated before or shortly after discharge, resulted in a significant improvement in a combined endpoint that included deaths from cardiovascular causes, hospitalization, and or urgent visits for heart failure. There was a 33% risk reduction in the primary combined endpoint with these therapies. We also have evidence for rapid uptitration as an implementation strategy from the Strong HF trial, which demonstrated that an intensive treatment strategy with uptitration and optimization of guideline-directed therapies within 2 weeks of discharge is safe and effective in reducing all-cause mortality and heart failure events from the Strong HF trial. And this study showed that there was evidence of improvement in symptoms, quality of life, and that reduction in the combined endpoint of all-cause mortality and heart failure events at 6 months following this intensive optimization. And this solidifies both the safety and efficacy of initiation of these therapies early without delay in all patients, including also hospitalized heart failure patients.
Thank you, Bikram, for introducing the dual concept of SGLT. SGLT1/2 inhibition with the soloist trial, we know that there's evidence also suggesting that dual inhibition may go beyond predominantly heart failure related effects of the SGLT2 inhibitors to also offer some protection from ischemic events. Maybe you can tell us a little bit more about this benefit and particularly the SCORED trial.
I'll first start with a perspective on the soloist and then expand because there are so many interesting things that we learn from the soloist trial. As a reminder, soloist trial included patients with type 2 diabetes with recent worsening of heart failure, and the initiation of therapies were in the individuals who were hemodynamically stabilized, but the therapy was started very early, before discharge or within 3 days of the discharge, and included patients with both REF as well as PEF. And I think approximately 20% of the patients were PEF. This is a sick population. They have a very high event rate. And the risk reduction was seen both in individuals with reduced EF as well as preserved EF, in individuals who were treated both before discharge or after discharge, or in all the subgroups, including men and women, and including individuals with low eGFR less than 60, as well as above 60. And the separation of the curves in the soloist was also very early, within approximately a month of initiation of therapies. And in terms of the SCORE trial, the SCORE trial added, it was a companion trial to soloist. SCORE trial included patients with diabetes and chronic kidney disease with the eGFR between 25 all the way down to 25 and 60, and high cardiovascular risk, either individuals with cardiovascular risk or established cardiovascular disease, and evaluated soloists in a broader cardiometabolic population. And as I mentioned, it included individuals with a little bit of a sicker CKD profile. It also demonstrated a significant reduction in the combined endpoint, a 26% relative risk reduction with sotagliflozin in the combined endpoint of cardiovascular death, heart failure hospitalization, and urgent heart failure events. The attribution of reduction events was predominantly due to reduction in heart failure events. It was seen both in individuals with reduced and preserved EF. And interestingly, the co-primary endpoint included also cardiovascular death, non-fatal MI, and non-fatal stroke. And this achieved significance by a reduction of 23% in this trial. This is a signal that is not commonly seen with other SGLT inhibition. And the pre-specified exploratory analyses also showed a reduction in the fatal or non-fatal MI, the total number of MI events, as well as fatal and non-fatal stroke events. So this is rather intriguing as to in patients with diabetes and chronic kidney disease, the sotagliflozin therapy results in reduction in cardiovascular deaths, heart failure hospitalization and heart failure events, but also cardiovascular death, MI, and stroke. And the benefits in terms of the MACE events were consistent across individuals, including prior coronary cerebrovascular disease or without prior established cardiovascular disease. Now, let's take a closer look at this dual SGLT1 and 2 inhibition and address the considerations for its implementation in clinical practice. Bassam, what is the current indication for sotagliflozin, and what are your perspectives on its position in the guideline-directed therapies? Which patients might benefit the most?
Right now, sotagliflozin is actually FDA as well as Emirates Drug Establishment here in the UAE, where I'm currently based, to reduce cardiovascular death, heart failure hospitalization, and urgent visits for heart failure, and patients who have heart failure or patients who have diabetes and CKD plus other cardiovascular risk factors. And all of these indications are derived from the soloist and scored the trials, which you nicely went over. The potential added benefit and which categories or which specific group of patients may benefit more from this dual inhibition may include patients who have more overexpressed SGLT2 cotransporters. We can think of patients who have CKD and diabetes and heart failure. You also went over the potential ischemic benefit for this class of dual inhibition. So we can also think of patients who are at high risk of stroke or ASCVD. Also, as we go over the pharmacology of these medications, the fact that they can also lower postprandial glucose, we can start thinking of a group of patients who have high postprandial glucose who may also benefit more from this class of dual SGLT1 and 2 inhibition.
You're pointing out very important concepts regarding the differentiators of SGLT1 and 2 combined inhibition. Mechanistically, give me a little bit more of a perspective on what exactly is the one in addition to two ads. Why might it matter clinically?
So we know that SGLT2 are mostly expressed in the kidneys, where they reabsorb about 90% of filtered glucose. And we think that when we block or inhibit SGLT2, we prevent this 90% reabsorption. But in fact, there's also some compensatory mechanism that happens at a more distal part of the proximal convoluted tubules in the kidneys, with the SGLT1 compensating by reabsorbing more than it usually does. So SGLT1 cotransporters are located on the proximal convoluted tubule, but at a distal segment. So blocking SGLT1 will also help this prevent this compensatory mechanism of glucose reabsorption. But also importantly, these cotransporters, the one transporters, are also located in the intestines at the brush border of the small intestine, preventing glucose absorption in the GI tract. And this is also very important in reducing postprandial hyperglycemia. Also, they're located in other organs, including the brain, the heart, and this can have also potential benefit in reducing oxidative stress. Interestingly, now we hear a lot about the GLP receptor agonists. They're also involved in modulating hormones like GLP1 and GIP. So we think that again, this is also a part of the hypothesis of the benefit that we are seeing, that they may contribute to plaque stability, to weight reduction, some of the things that may explain the ischemic benefits that you went over as well.
And regarding the use of the SGLT1 and 2 inhibition, any guidance on how the clinicians should use the SGLT1 and 2 inhibitors?
That's a very good question, Beacom, that frequently comes up in practice also. Even if we start with hospitalized patients, when should we start these medications? And we look at the soloist and other trials on how they utilized in admitted patients. We need to have the patient hemodynamically stable when hospitalized before we start these medications. As far as the dosing and other consideration with the specific class of dual inhibition, starting them at a dose of 200 milligram and then titrating to 400 milligram, preferably given before the first meal. The idea being that you want to reduce postprandial glucose. Other considerations of when to prescribe them, as we mentioned, obviously there are renal considerations that we need to think of, but we can get to these as we go.
How about safety? Are there any differences with the dual SGLT1 and 2 inhibition with sotagliflozin compared to the SGLT2 inhibitors?
So SGLT inhibition as a class have known adverse reactions. These include mostly genital hepatic infections. A lot of times we confuse these with UTI. The class effect of these medications and the dual inhibition is similar. The consistent adverse reactions that we see or adverse effects that we see are genital mycotic infections, and with the dual as well, the diarrhea. Urinary tract infections numerically in some of these studies, but not all of these studies, have been also increased. But in practice, I would not deprive a patient with history, for example, of a UTI from getting this medication if they do not have an active UTI at the moment. Another consideration, as I said, the GI side effects, potentially diarrhea, but also we know that these drugs can cause some natriuresis and diuresis. These would be, in a nutshell, some of the considerations that we think of as we initiate these medications.
And are there any concerns regarding the kidney? Should the clinicians be aware of any of the concepts for management in patients with kidney disease?
Sometimes in practice, when we start this medication and you see a little bit of a bump in the serum creatinine, clinicians and the patients get concerned. But we know that there is an expected initial EGFR bump when we start SGLT dual or 2 inhibition. But this initial increase in serum creatinine is not due to any kidney damage, but rather this is an expected hemodynamic effect that you see with this medication. And in fact, this hemodynamic effect is due to a reduction in the intraglomerular pressure, which long term has a beneficial effect in protecting the kidneys. So, similar to what we see with ACE inhibitors, where you see an initial increase in serum creatinine, but long term, we know they are renal protective. As far as particular cutoffs, we follow the trials. And with the dual SGLT1 2 inhibition, the cutoff for starting these medications included an EGFR of 25. Particularly patients actually who are borderline getting to potentially worsening renal function and end stage, these patients may benefit from this class of medication. But the safety data as far as uh, up to what limit of EGFR we can start these medications, I would say 25 ml per minute according to the trials.
Excellent. So, to recap, SGLT inhibition is very effective in preventing heart failure in patients with diabetes and chronic kidney disease. It's very effective in preventing adverse outcomes such as cardiovascular death and heart failure hospitalizations in patients with established heart failure across the whole spectrum of ejection fraction, including patients with heart failure with reduced EF, mildly reduced EF, and preserved EF. Also, including individuals that are with decompensated heart failure, that are hospitalized for heart failure, with evidence of safety as well as efficacy across the whole spectrum of heart failure. These agents are disease modifying. Their benefit is seen very early, immediately within a few weeks after initiation. Therefore, therapies should not be delayed. And the safety profile is established across thousands of patients for the heart failure populations and should be implemented as a cardiovascular disease modifying agent for all patients with heart failure. But any additional comments from your perspective?
Yeah, I certainly agree, Beacon. This was nicely summarized. We can also say that for the dual inhibition, their effect include the metabolic and intestinal effect, which may add benefit to particular patients, including those with uncontrolled postprandial glucose. We've also seen a signal toward potential ischemic benefit, which can be explained as a potential theory by their glycemia effect, improving that endothelium, again, reducing oxidative stress. So, potentially, patients at high risk of ASCVD or ischemic events can also benefit from the dual inhibition.
Bassam, thank you so much for this outstanding discussion. And I would like to thank our audience for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation. Thank you.
Thank you, Beacon. I very much enjoyed this discussion.
This program was presented by Medscape Education Global.